you can see in high-risk population, the detection rate is 2%, but in non-risk population, it's about 1.6%. That is to say, if we don't screen the non-risk population, we will gonna miss almost half of the lung cancer we should have detected. So here, the conclusion is the high-risk criteria in the past can help us to enrich the lung cancer patients. We have already presented our hospital, which focus on respiratory medicine in China and have a big cohort over China and a large sample tissue bank. And our studies focus on the precise early management of lung cancer across the screening, diagnosis, and resection, and recurrence prediction and treatment. First of all, lung cancer is a chronic disease and provide us a window to identify the early stage lung cancer or precursor and give the radical treatment with the intent for curative treatment. And according to our surveillance study in the population, we could see the lung cancer screening by CT scan can increase the proportion of stage 1 lung cancer we can identify, and then can reduce the populational lung cancer mortality at an extent much was higher than those new drugs developed for late-stage lung cancer. According to a lung cancer screening project in which conducted by our team in Guangzhou, we could see here the previous high-risk criteria is not eligible in China population, and I think it is similar among other population in the world, because in the past we focus on only those with smoking history and those with family history of lung cancer. But however, in our study, we could find that the population outside this criteria share the similar or non-inferior detection rate of lung cancer. You can see in high-risk population, the detection rate is 2%, but in non-risk population, it's about 1.6%. That is to say, if we don't screen the non-risk population, we will gonna miss almost half of the lung cancer we should have detected. And especially in the non-risk population, the stage 1, which consider curable disease, will have a more higher proportion among the non-risk population. If we miss this population, we could miss a lot lung cancers that can be curative. So here, the conclusion is the high-risk criteria in the past can help us to enrich the lung cancer patients, because we could see even in high-risk population, the detection rate is only less than 2%, and in non-risk population, the detection rate is also very high. And also, the CT is not the optimal screening tool, even we think it's the golden standard, because the CT scan, the high sensitivity can yield a lot benign disease and indolent lesion. So we should change our thoughts about the lung cancer screening right now, because we have a more effective tool. So we developed another assay by the ctDNA fragmentum, which use only low-depth whole genome sequencing, which means it's less expensive and cost-effective. And we developed this assay with a lot of cooperators. And then this assay, we could see by a screening model, which differentiate the lung cancer cases from those with benign nodule and healthy controls. The AUC is about 0.93. And by the simulation, we could see here, the ctDNA screening share the similar sensitivity with the LDCT, but have a higher specificity compared with the CT scan. And we are now performing a prospective randomized control trial to compare the ctDNA fragmentum text with the traditional LDCT for the screening of lung cancer. We expect the positive predictive value will be much higher than LDCT. And about the lung nodules identified by the LDCT in the screening project, we can see we have a lot over diagnosis and treatment. According to a survey among the top hospitals in China, we could see the nodules being resected. The final pathology result come about 1/4 of the nodules being resected to be benign nodules. So that means we don't have enough diagnosis to before the surgery to determine our decision. We developed the first ctDNA methylation high throughput sequencing technique to differentiate the benign and malignant nodules in different types. We finally enriched 100 typical loci in the methylation as the ctDNA texting. We could see the AUC to differentiate the benign and malignant nodules is about 85%. According to a prospective validation study in China. And we also combine the radiomic AI with the ctDNA methylation to build a multi-modality text. So we combine the features of the image and the biological feature by the ctDNA methylation. So the final AUC, we could see the synergistic effect is about 91%. And we could even differentiate the very tiny nodule less than 1 centimeters with the same accuracy. We are now translated into a practical in our real world. We could see here, we can reduce almost 90% of the overtreatment and 73% of the delay of the treatment. And in some typical cases, we could see here a very tiny nodule, but we find by our model is the high risk, and finally it becomes a microrally invasive adenocarcinoma in just several months. And for the benign nodules, we could see here a very solid and big nodules, but we detect it as a low risk, and then after follow-up, it's become smaller. So we are now performing another randomized control trial by comparing whether we add this Homocyc plus model before the decision of the surgery to see if we could reduce the benign rate of the resected nodules. Another is how to early intervene our early stage lung cancer identified by CT scan. Firstly, by multi-omic methods, we identify some driver genes like EGFR mutation and some immunoevasion like the PD-1 overexpression as the drivers to let the cancers occur. But is it the target? So we have to test it using the drugs to intervene. First of all, we performed the first trial to test whether the single agent PD-1 antibody can have effect on the pre-invasive lesions like the granular opacity in density. Here, we can see some active signals. We can see here a very early lesion. Using the PD-1, we can see the infiltration of the immune cells, and then finally it has complete response and disappear. So it is for the first time you could see to anti the immune evasion, we could reverse the lesions. And then for some targeted therapy, we could see here by the mouse model, we established a granular opacity ground glass opacity like early lesions. So by the mouse model, we test the EGFR TKI can clear the lesions, which is spontaneous EGFR mutated lesions. And then we establish a radiomic AI to identify the EGFR mutated model, mutated lesions without the biopsy. Then we performed the first proof of concept study to see. We use only the AI image to identify the EGFR mutation among these lesions. And then without biopsy, we deliver 2 months of third generation EGFR TKI to see if this modality work in such early lesions. By this study, you can see here, the response rate is about 60%. And this is typical case to have the response of the early stage lesion. And we could find the AI score for the EGFR mutation and the malignancy will also decrease along the region, as long as coming along with the treatment. So we could see here, even in some very typical cases, the multiple lesions can be reduced by the EGFR treatment. So many patients don't have the multiple surgery. But another issue is if we withdraw the drugs using only 2 months and then follow up, we could see almost 80% of the patients will experience the recurrence of the lesions. You can see here the initial response, but after that, with the withdrawal, the lesions come back. So we should have to consolidate the response. But because we can use the EGFR TKI for lifelong, so we have to use the immune surveillance. Then we designed and developed the first EGFR mutant neoantigen mRNA vaccine, including the major types of EGFR mutations. Because in Chinese patients, we have 50% of the EGFR mutated patients. So this vaccine can work in half of the patients in China. We have completed the in vitro study and also the first in human study to see the safety and effect. So first of all, we found the vaccine is very, very safe without any rash. So that means the no off-target effect. And then 80% of the patients receiving the vaccine will show the immunogenicity presented by the positive ISOPT testing. And then because we enrolled only the highly resistant patients who show resistance to EGFR TKI and chemotherapy. So when we use the PD-1 combined with the vaccine, we could see the PFS rate is 5.7 months, which was much higher than using only PD-1 itself. We could see some durable response after using the vaccine. So it means it indicates the anti-tumor activity even in very resistant tumor. These are 2 typical cases showing only using the vaccine single agent, we could see the response. And in another case, we could see the complete response after the combination of PD-1 and vaccine. We don't expect the vaccine to be very effective in that late stage, but we still see the activity. So that means the immunogenicity is much higher than we thought. And in the mouse model, we also test whether this vaccine can prevent the occurrence of lung cancer and the future nodules, early lesions. So here we could see some signals by using this vaccine, we could prevent the occurrence of lung cancer in this spontaneous happen model. So we are now performing an in human study to see the preventive effect. So finally, using the early screening and the early intervention method, and even some prevention methods like the vaccines, we taking them together, maybe we will have a dream to zero the lung cancer. So that's my presentation. Thank you very much.